Good morning, and I'm going to get started. Just a couple things from historical perspective. So Dr. Tsung and I have worked together for a long period of time. So we started working together at the NCI, surgery branch of the NCI, Washington University in St. Louis, UCSF, and here. So it's been many years that we've worked together. And J. Engelbert Dunphy is a rather famous general surgeon. He made these hypotheses when he was at the Brigham Hospital, part of Harvard Medical School. He later became chief of surgery or chairman of surgery at UCSF. And the title of our talk is Dunphy's Puzzle Revisited. Is it time to consider anti-tumor immunity or anti-tumor, the presence of anti-tumor immunity in cancer surgery? So in 1950 and 1953, Dr. Dunphy published two papers in the New England Journal of Medicine discussing some of his personal observations on cancer cases. They were both essays or opinion articles. The essence of his essays is to challenge the mainstream thinking that cancer is a constantly progressive disease. And he observed that there's factors present in some patients that affects outcome. And that factor he called natural resistance. So what were Dunphy's observations? Well, the first one was the counterintuitive behavior of tumor growth. The fact that tumor growth wasn't always progressive, but rather what he called uneven. And it was uneven between similar patients with similar diagnoses, and uneven even with the same patient at different times. During the observation, sometimes the tumor would grow quickly, sometimes it would be not growing at all. An uneven progression among different metastases in the same patient. So he noted that there was a difference in tumor growth. And then there were unpredictable consequences of surgery. So for example, if he did a radical operation on an early tumor that he thought would be curative, sometimes that patient presented with widespread metastatic disease in a very short period of time. Or sometimes when he did a palliative resection in a patient that had, tumor, the patient did well for a long period of time. So there were differences in the behavior of patients and the behavior of the tumor. So he postulated that there must be natural resistance. That's what he called it, natural resistance that influences the behavior of the cancer. And now we call that natural resistance concomitant anti-tumor immunity. So what is known today? So anti-tumor immunity is a decisive factor in cancer survival. The presence of anti-tumor immunity affects surgical outcome. And a decision to use surgery as a treatment plan should consider the presence or absence of anti-tumor immunity. However, this is not done. And the reasons it's not done is we don't know how to measure anti-tumor immunity. We don't know which patients actually have anti-tumor immunity. So we're going to give some data in patients later on to maybe determine how anti-tumor immunity is present. So the reason we don't do this is because to incorporate the concept of anti-tumor immunity into surgical decision-making, we really don't know how to identify and measure it. So that's kind of a leading challenge that we have. But we do know that immunologic function of surgery is important. Surgical excision removes tumor antigen. So if you do a complete resection, antigen clearance is a prerequisite for the formation of immunologic memory, which is responsible for post-surgery protection against recurrence. If you do an incomplete resection and you leave tumor behind, tumor antigens are still present, and this leads to immune tolerance and not memory. So we want to lead to memory but not tolerance. Antigen levels alone do not determine the immune outcome. There must be an immune response or antigen recognition. And antigen recognition is critical to the development of anti-tumor immunity. It's the critical factor that influences prognosis in cancer patients. Surgery affects concomitant immunity in two ways. As I mentioned, immune memory results as the development of complete tumor resection, where immune tolerance is incomplete resection. So the hypothesis we have is the status of anti-tumor immunity determines whether surgery is potentially curable or not. The reasoning behind this hypothesis that cancer cells are known to disseminate long before even clinical detection. So every study that's measured circulating cancer cells have found circulating cancer cells in all patients. And the circulating cancer cells actually increase during the time of surgery. So a cure is a result of either elimination of new metastases or lifetime immune protection or memory against subsequent metastases. Since occult metastases may last a long time, the best chance of cure depends on enhancing immune protection. And this is an important observation from the New England Journal in 2003. This is a patient who had a long history of melanoma. So she had melanoma surgery 16 years previously and had never had any evidence of recurrence. And then she died in a motor vehicle accident. And her kidney was transplanted to a recipient who had no melanoma, no history of melanoma. And that patient developed systemic melanoma. Of course, that patient was immunosuppressed because of the kidney transplant. But that patient developed systemic melanoma and died from that in a relatively short period of time. So the observation must be that that melanoma was present in the kidney, because that's a picture of the kidney with the melanoma in it. So that melanoma was present in the patient who had the melanoma previously for 16 years in kind of a fashion that was not detected. So post-surgery recurrence is dependent on anti-tumor immunity. And so Dr. Tsung is going to show some experimental data we have to kind of address these questions. So the first question is, tumors of low concomitant anti-tumor immunity have a greater tendency to recur post-surgery. That seems obvious, but that's important to actually prove. Under conditions of increased concomitant immunity, tumors should have a lower rate of recurrence post-surgery. And of course, like in that patient with the melanoma, immune suppression will result in higher levels of post-surgery tumor recurrence. So now we're going to hear from Dr. Tsung, who is going to give us some animal data and then human data.
Thank you. I just need to switch to, that's okay. Go ahead. Okay, so I'm gonna.
I don't think your mic's on.
It is.
Okay.
Wait. Okay, so there are actually 3 predictions that Dr. Norton just set on the previous slides. I'll just rerun them just to make sure. Those are actually testable predictions that I'm going to run through the rest few slides in 5 experiments to talk about these predictions and the related experiments. The first prediction again is that tumor, if post-surgery recurrence is protected by anti-tumor immunity, then tumor of low concomitant anti-tumor immunity will likely recur after surgery. So in order to test that, we choose 3 tumor models with different known testable concomitant immunities, and the PAN02 is a well-known spontaneous mouse tumor of pancreas, and it has very low or non-immunogenicity. And the Cln26 is another well-known, well-used tumor that has a weakly medium concomitant immunity. And the last one is called MCA207. It's one of those so-called Rosenberg tumors that we inherited from the surgery branch. It has relatively strong concomitant immunity. And so using these 3 models, what we want to do is with a different known immunogenicity, we want to see whether the prediction is consistent. In other words, a low immunogenic tumor after surgery would have a quicker or more recurrence compared to a high immunogenic tumor that would have a low one. As the data shows, you can see these are tumor subcutaneous tumor 7 to 10 millimeter after 10 days, around 10 days, then surgically removed completely subcutaneous tumor, then left just for observation of recurrences after surgery. And you can see the one Pan02 has very low immunogenicity and has very high recurrence rate immediately after surgery, while the MCA207 has very high concomitant immunity, has a very low recurrence rate. When we say the concomitant immunity, this actually MCA207 is known to resist any even live tumor challenge once there's a primary tumor present, and a challenge put on the other side is usually rejected. On the other hand, Pan02 never rejects the second challenge, therefore it is non-immunogenic considered, and the C26 would be intermediate in this case. So as you can see, this is consistent with our prediction, at least for the first prediction. The second one is called under conditions of immunogenicity, immunity suppression or removal. Tumor of strong concomitant immunity, anti-tumor immunity will decrease post-surgery. As we shown in this one, it has a very low post-surgery natural recurrence. So the second one, we use the MCA207, which has a strong concomitant immunity. Then after surgery, this one naturally would not have a natural recurrence. In this case, it's 0 out of 10. So after surgery, we did two things to lower its immunogenicity or immunity. One is by T-cell depletion, of course, using antibodies to CD4 and CD8. And the other one is we'll give an intensive chemo mimicking a post-surgery high-dose suppressive chemotherapy. This is a 5-day consecutive 5-FU that lowered the white blood cell count to relatively low levels. Now, to see whether there's a lower of decrease of protection, one is to look for observation of natural recurrence, and the other is in case they don't happen, we actually re-challenge the mice after surgery with 1 × 10⁵ cells. Now, as you can see, the naive control, 100% of the naive will be taking tumor under these conditions. Now, the data says without any T-cell depletion or suppression, there's no natural recurrence in this case, and there's a very relatively low tumor take or high protection under this condition, supporting it is a immunogenic tumor. And but under T-cell depletion, we will start to see recurrences and also lack of protection against challenge. The intensive chemotherapy also brought similar effects in these mice. It should be pointed out, in this case, when we have the natural recurrence and the lack of protection are usually go hand in hand, happening in the same mouse. When they have natural recurrence, they always have loss, rejection of the challenge, which is normal. And this is a typical immunological behavior. So this experiment actually proved that the immunity, T-cell immunity, is important for post-surgery protection against either natural recurrence or artificial challenge, metastasis challenge at the distant site. So once it is, we know that it is the immunity that protect recurrence or metastasis post-surgery, then we want to see anything we can do to, the third prediction is if that is the case, then can we increase that protection by some way? And so this is what we did in the experiment. The panel A shows the experiment flow, which is we use the C26 colon tumor because it's a medium height concomitant immunity tumor model, so we can increase it to a stronger, hopefully to a stronger protection. And so we inoculate the mouse with the tumor, and this is 2 weeks after inoculation. This is relatively a larger tumor of sometimes over 10 millimeter, but 8 to 12 usually in size. Now, then we had a surgery on these tumors. After that, I'm sorry. At day 14 before surgery, we did a treatment. Now, to increase the anti-tumor immunity, the non-treatment, and this is the groups that we have used for the treatment. We have done this before this many years. We've done that. We know chemotherapy in the tumor model of an immunogenic tumor model, like C26 or MCA2, is able to enhance the pre-existing anti-tumor immunity by releasing tumor antigen. Therefore, we had a group also treated with a cyclophosphamide as a chemotherapy. And we also know by previous study that IL-12 interleukin that is for Th1's response promoting cytokine, or chemotherapy combined with IL-12 is very powerful to increase the pre-existing anti-tumor immunity, leading to even eradication of existing tumor. So in this case, we have after tumor inoculation, before surgery, we had 4 groups now. One is without treatment, direct surgery, and one is treated with chemotherapy, then followed by surgery. One has IL-12 alone, and the last group have a combination of chemotherapy plus IL-12. So then we have a surgery on them after all the treatment, immediately after the treatment, and then we wait for another 10 days. Then we challenge these mice with 1 × 10⁵ tumor cells to see whether there's a change or increase or decrease of protection against its artificial metastases. Now, panel B shows the result of this readout. The top one shows actual tumor resistance to challenge, and the bottom shows the gross tumor size in case there is take of tumor challenge. First 100% tumor taking naive control with the challenge, that is the control group. And if we had just had surgery on the tumor-bearing mice, we would have 2 out of 16 mice protected from the challenge, and the rest of them are growing. You can see the tumor size here at day 18. And if we had treated the mice before surgery with the chemotherapy, that did not increase much of the protection rate, 1 out of 10% protected. The tumor grows slightly slower after taking tumor. The big difference are mainly from the 2 groups associated with IL-12 usage. One is IL-12 alone. 4 out of 9 mice are actually rejected the tumor challenge, and the tumor grows very slow relatively. But the other group has 13 out of 17 completely reject the tumor challenge. So this experiment shows that if we use some way we know that is able to increase the immunity before surgery, in this case either chemo or chemotherapy plus IL-12 or IL-12 alone, then we do get a increase. Those are actually protection translated post-surgery. So something we did before surgery will actually translate into a benefit after surgery. So I'm going to show you two related, if that is the case, I'm going to show you two related experiments that is related to the clinical situation. The question is, if post-surgery recurrence is protected by anti-tumor immunity, shouldn't we make surgery decision based on status of anti-tumor immunity? If that is the case, then there's a conflict. For example, the timing of surgery would be based on immune status or based on, for example, tumor burden. That's something facing in the surgeon in a clinical situation. And the second related experiment is we're going to discuss more on something called delayed recurrence in the clinical setting, because the previous experiment I'm showing you is a recurrence after manipulation in a short period of time within 3 months. But in the clinical setting, it is usually the recurrence that delayed after latent period of tumor-free then come up. That is the most challenging. So we have, with the animal models, hopefully we can deal with that situation. That is the experiment we're going to discuss. The first one is when is the best timing for curable cancer surgery? That question, because there's a tumor burden change, and that usually is based in a clinical situation, or as we raise the issue that maybe it is a status of anti-tumor immunity. Sometimes they go hand in hand. Of course, with a strong immunity, you have a lower and smaller tumor, no metastasis. Of course, in this case, it is consistent, but not necessarily always. For example, in this experiment, we have designed it deliberately to challenge that issue. And so panel A is a diagram of the tumor size change under chemotherapy using the MCA-207, which is immunogenic tumor. And even that is immunogenic. Because it is immunogenic, we know previous study that it will respond to chemotherapy. Now this response is partly by direct killing by the chemotherapy drug, but mainly by the anti-tumor immunity activated by the chemotherapy. Therefore, when we see a response, we should keep in mind that there's an activation of anti-tumor immunity for sure. Then, because the tumor is relatively large, it can't be cured by by chemotherapy alone. It will have a response and will have a rebound. Of course, when you treat it again, it starts losing that response, like clinical situation. Now, using this, we have set the points from A to G. The reason for those points is we want to see at which point the immunity status is known, and we don't know whether that, at that point, if we resect the tumor, and then we'll see the protection after resection will translate, will the anti-tumor immunity correlated with, or it is the tumor burden that correlated with post-surgery protection. For example, at the point C, which is during response towards the bottom, because we've done many of those, we know roughly how many days they start to lose response and start to get a rebound. And so at C point, mostly are still almost, are continuing going almost the deepest response you would get, but then you wait until it starts to rebound a couple of days after response reached the maximum at point D. Tumor burden-wise, C and D are roughly same, but D is much smaller than A and B and all the other points for sure. Now, if you look at protection, now this is the same way. We have surgery at taking mice, 10 or at least 10 mice from each point, then we resect the tumor. Then we keep them all tumor-free, then challenge them together with a dose of at least 100 times, 1 times and 5 times the best. Tumor cells. Then we want to see protection against, this is mimicking a metastasis or recurrence. It's a forced one, of course. But you see the point. For example, at point A, which is a tumor, so-called tumor bearing, this is an immunogenic tumor model we've shown before previous experiment. It is going to protect, yes, mostly protected, the challenge. Now, B point is one that we know once we give chemotherapy, when they start to respond, the immunity is highly activated at this point, even though the tumor size is still large. So the immune status is high at this point. So it's associated with almost a complete protection of any challenge. Now, at C point, the tumor burden is much lower than B, but it's still doing immune response. It is also highly protected at this point. But then when it started to rebound, and we took mice from point D, and we can see it started to lose protection, even though the tumor burden-wise, it is relatively same as a C and much smaller than all the other points. Of course, the other later points, we know that the immunity has been decayed and the response is lousy, and you can see the protection is not good. So what this experiment shows you is that it is true. When you face a surgery decision, there are two potential factors you need to consider. Most surgeons consider tumor burden because that is what a lot of neoadjuvant chemotherapy purpose for that. But actually, a lot of times the neoadjuvant chemotherapy is known to activate anti-tumor immunity as well. So in case this experiment shows, you might want to consider the actual status of anti-tumor immunity for the best surgery point. So the other related question for a clinical situation is something called a delayed post-surgery recurrence. Is that a result of also immunity decay? And if it is, how to correct that? It is the delayed post-surgery recurrence is actually a phenomenon that we all know. We call it recurrence of metastasis because it is usually happening after a latent period of tumor-free, then the recurrence start to take place, and within 1 and 3 years, it's usually the peak, and after that it slows down. After 5 years, almost down. That's what we call cutoff for clinical cure. So this is the most difficult to deal with because for the short term, usually we could use a chemotherapy, for example, radiation, control the immediate recurrence following surgery, but for those long with delayed recurrence, there's no method that works that will control it. So we think it is most likely due to timely decay of anti-tumor immunity because the recurrence is a balance between residual metastasis and the immunity. Here's a model we can try to explain what we think. This is a model, what we think. For example, the right line is the possibility of recurrence after surgery. See, by the point of his surgery hit, all the new accumulation of dissemination, tumor dissemination has stopped. And therefore, all the recurrence will be coming from previously deposited, disseminated tumors. And usually there's a peak after surgery because it has accumulated the maximum amount of potential metastasis. Then with time decay, these metastases, the one that can form angiogenesis, can form blood supply, should have established that. And that possibility drops with time because the tumor disseminated that could not form independent blood supply would not do that with time lapse. And the green one here shows potential protective power of anti-tumor immunity. Of course, immediately after surgery, in the immunogenic tumor case, it is left at the maximum strength. And without further antigen stimulation, it's going to decay with the time. In the case, for example, we're talking about a delayed recurrence between 1 and 3 years. In this case, when the protective power of immunity decays to a certain point below the threshold, then any new even though less frequent metastasis shows up, it's going to show up without immunity protection. So this is the model we're thinking about. We'll try to see whether that is the case. Now, if it is, so with that model, that what we think is we can't change this line because it has already happened, it's there, we don't see it. But what we could do is we can lengthen, try to extend the protective period by doing something, enhance the immunity or enhance its, or slowing its decay. So there are possible ways to reduce immune decay that by basic immunology we know that. For example, we have just shown that with the short-term protection model that we could probably increase pre-surgery immunity. That's something we could manipulate. We also know from what Dr. Norton's introduction that the function of surgery is to clear antigen, and antigen clearance is a prerequisite for memory formation. In case there is a memory formed, it is usually long-lasted. So to form a good immunological memory is one thing we can do to lengthen the protection. And finally, in case we can't, and there's always ways to use repeated antigen stimulation to maintain an ongoing immune response, and in that case what we call tumor vaccine would be something we have tried a long time previously. So the evidence for post-surgery immunity protection occurs in our model is that it is due to immune decay, but there's no proof for that. And all we know is in the clinical setting, we have a supportive evidence for it. So for example, it is a T-cell infiltration correlated with the post-surgery prognosis, many publications on that. That is consistent with what we're saying. And the latent metastasis preceded by long recurrence-free period, and there's no reason to think the cancer cells so smart to wait until your certain point to start coming up. They have been continually coming up like what previous model. It's just that you don't see it because the immunity has wiped them out, and it's called immunological surveillance or whatever. There's an explanation for that. So it's consistent with that. And also consistent with that, when in late-stage tumor cancer cases, when there's associated with general decay of immunity, there's an explosive growing of tumor cells everywhere. That is also consistent with that, but there's never proof. But in the animal study, there's also no proof because they haven't been specifically addressed. The reason for that is technically we don't see delayed recurrence in non-immunogenic tumor model as we've shown in the first experiment using PAN02. It will just come up quick without immunity. That's why we have the model showing you the metastasis or recurrence are coming up regardless of whether you have immunity or you don't. It's just whether you see them or not, the immunity make that difference. For non-immunogenic tumor model, that's usually the way. It will come up immediately. Now, so you can't use that to study a delayed recurrence model. Now, for immunogenic models, people have used it many years, but usually these models are tough. They don't come up with immediate recurrence, but nobody knows whether they'll come up with delayed recurrence. As long as I've looked, or I know, people keep them in 6 months or a year, there's still no recurrence happening. So actually, it's not done whether they have naturally recurrence after a long period of decay. But we think from all previous experiments, we think there's a chance that they will, but so it has to be done, that experiment regardless. So we have decided to take a long time to do that, and that is what we did. First, we used the immunogenic tumor model, MCA207. We thought if we want to do this experiment, we do it to the maximum. In other words, This one is very immunogenic. If the top immunogenic tumor model will have delayed natural recurrence, you can believe all the weaker ones will have it. So this is more like a one experiment you can pretty much conclude. So we use that model. And the problem with that, of course, is the so-called delayed recurrence in human is usually after 1 year, between 1 and 3 years, or between 1 and 5 years. For the mouse, they don't live that long. Maximum lifespan is about 3 years, plus the experiment, all the other factors. We roughly have about 2 and 2.5 years of a waiting period. Will that happen or not? So this is a risking factor, but this is what we did. So to increase, to also answer the question whether if it happened, then can we prevent it from happening? Therefore, we have used the 4 groups that we used before to enhance the immunity before surgery, therefore to see whether it will translate into a protection of delayed recurrence. So the end point will be, first, we're going to wait a long time, and we're going to wait for spontaneous tumor recurrence. And if they don't come up after 2 years, then we will challenge them by counting the tumor take to see whether, compared to early ones, for example, down to 6 months, to see they have actually decayed the protective power. So we will be able to do it regardless. Of course, if we have a spontaneous tumor recurrence, we're going to look for the tumor cancer-related survival. Luckily enough, the experiment actually worked. This is a recurrence curve, a Kaplan-Meier graph analysis showing this is a fraction of tumor-free mice after surgery. Of course, at the beginning there's no tumor because, like I said in the previous experiment, similar down, that is with tumor inoculated, then treated with a chemotherapy plus L12 or L12 alone. Then we resect the tumor completely. Then we left them for observation. Now, anyone that had a recurrence within the first 6 months were excluded as incomplete surgery or other reasons. So we're looking for delayed recurrence in this case. As you can see, after long waiting, I believe the first, except this single mouse, the cluster of recurrence started to take place after 18 months. And so then from the recurrence happening, the only 2 groups that are statistically significant compared to surgery alone would be one associated with IL-12, just like the short-term experiment we have done with the C26. This is actually MCA207, 2 different tumor models, but the similar treatments, again showing that IL-12 alone modification or chemotherapy plus IL-12 translate into a much better protection post-surgery. This is actually natural recurrence like a patient, so we did not challenge them. Of course, they translate into delayed, a significant survival benefit. I don't need to show that. Point is, I want to see something about those recurrence. Nobody ever observed them. There's no report on those natural recurrence, what they look like. Actually, there's a few points there. They resemble, a lot of ways resemble a human cancer recurrence. For example, the recurrence is actually windowed in a period like a human. 1 and 3 years, after 5 years. Why it's called clinical cure? Because it never happened again, rarely happen again. Same in the mouse situation, although in this case we don't have the mouse to go into 5 years. But lucky enough, we've seen the cluster of recurrence happening between 18 and 25 months, and the mice continue to live a few months after that, therefore, and without any recurrence happening. So this is more like a human case after a certain period. That is consistent with the model, the L-shaped possibility of recurrence. In other words, it has exhausted, even though regardless of protective immunity is there, it's not because it already happened with natural recurrence. But at least exhausted the metastasis. Now, the other one is the location of the recurrence. They're true metastasis or recurrence. They're not at the surgery site, and they're often multiple. And they're because there's a sarcoma, it's in the soft tissue and on the bone, it's in the shoulder, in the muscle, and visceral sites, it's mostly in the spleen. So in this case, they're true metastasis and a true recurrence. That has never been observed on immunogenic tumor model before. Now the tumor behavior after recurrence, they're like human cases a lot. In the case, there's slower progression after probable. This is different from what we inoculate a mouse artificially with an implanted tumor. They continually, steadily grow. But these ones, once we saw them become palpable, most of them have slowed progression. Now also, there's an occasional regression even selected site. Like a patient, Dr. Norton said, uneven. In that, there's a site of the two tumors, one tumor will be spontaneously regressing while the other were holding or actually slowly progressing. And in a couple cases, they show heavy necrosis and cause-induced cachexia and the death of the mouse from that cachexia instead of the tumor. So what actually these results mean, if you think about that, it has said a lot of things. For example, could immune surveillance prevent tumor dissemination? That's a big issue. Everybody says it has. It's a big theory out there. But this experiment, to think about it, it's very straightforward. It's an implanted tumor. After 5 days, we know concomitant immunity took place. From that day on, there's no way you can even challenge a tumor to that mouse. Now, we have spontaneous recurrence out of that, meaning that took place within that 5 days of tumor implantation. So the immunosurveillance works, but it won't work if it hasn't established in human. I'll show you in some of the analysis. In human, we think it takes time for the immune recognition to catch up on established tumor, but the metastasis never had time to wait. They'll start disseminating way early. I'm sure some of you know the circulating tumor cells were detected way early. So why metastasis show up late? Of course, then we have proved that it is delayed. It is the decayed anti-tumor immunity, and can we do something about it? Yes. If we can do at least one thing out of the three, we said at least one thing, boosting the pre-surgery anti-tumor immunity will translate to a post-surgery protection in that sense. So I've talked to all the animal experiment, but yes, I'm sure you're convinced, yeah, it looks like that way, but can we do that in human, incorporate anti-tumor immunity in surgery decisions? I've showed you why we should do that. We don't, I mean, the problem is how, Dr. Norton mentioned, we don't have a way of measuring it. So doctors depends on accurate lab tests to tell me, right now it is a high immunogenic status or it is not. Unfortunately, we don't have that test established, but this is more like a supply and need and supply issue. Once the industry know that we have this need desperately, they will develop something. I'm sure we have talked to some company. They are developing ways to measure or at least qualitatively telling us there's an immunity coming up, activated or not. So it will be resolved. That won't be a long-term obstacle. But for now, at least there are ways of we can detect this existence, for example, by direct view of immunity in tumors. This is based on two basic immunological principles. So one, immunity must accumulate at the antigen site. So anti-tumor immunity must be present at tumor site, period. Second, antigen-specific immunity is T-cell dependent. Therefore, looking for T-cell is a representative for looking anti-tumor immunity. So many studies have shown that, yeah, the tumor-infiltrating T-cells in solid tumors, many, hundreds of them. But all of them have one shortcoming. They were looking for single T-cell types CD4, CD8, a correlation of that, even Tregs and other type of T cells. But what we want to look now is a comprehensive way of looking not only the T cell and the number, but their distribution, their potential function. Because anti-tumor immunity, if it is true, is supposed to destroy tumor structure and inhibit tumor replication. So a combination, a combined view of T cell distribution and tumor structure makes more sense. After we look some of the we look at the T cell infiltration in that angle, we have some accumulated so-called rules so far that I will show you each of them. For example, there are some general patterns of immunity in different types of cancer, in other words, associated with a better prognosis, a worse prognosis. I don't need to say that, everybody know that, but also looking from our way of looking at it, it's also true. But point is, each patient may be unique and exceptional. I'm going to show you an example of that. And the distribution T cells anti-tumor activity, it is not even inside each tumor because it is distributed in this area stronger and in the other weaker. So this is saying you have to look the whole thing together, not just to pump a little hole in the biopsy sample to conclude the entire thing, even though, especially for surgery resected tumor, we would be able to look the entire section. And the other way is to look at longitudinal comparison between immunity of a given patient, for example, at biopsy, during the treatment, and finally at surgery. You can probably make more sense to see the increase or decrease of immunity. Only in that sense, you can conclude relatively solid. First, just a general patterns of association of post-surgery recurrence between immunogenic and non-immunogenic human cancer. Yes, there are immunogenic and non-immunogenic human cancers, we all know. But I'm going to show example. For example, high-grade glioblastoma, it is bad. Everybody know that. It can be resected completely and come back with regardless within 6 months, or even radiation delay a few months, it will die and recur. So observation is, yeah, this is a very few of them you can actually say immunity, and of course most of them die. So the other bad one is stage 3 ovarian cancer, because that's a special case. Usually surgery is done on that regardless because it's more palliative. It is a very high recurrence rate, and we can see very low immunogenicity in those cases. And another one is soft tissue sarcoma that has a bad prognosis, high recurrence. It has very low immunogenicity. But on the other hand, there are good ones like a breast cancer stage 2, curable by surgery. Everybody know that. But why? It has very relatively high immunogenicity or immune response associated with it. You can see it. One special group is people have a physical checkup, have a small tumor in the lung. Usually that's the case. They run to the doctors and they don't do anything, even not biopsy. They just cut it out, and the patient most likely cured. Why? You see, what group of that, they usually have very high anti-tumor immunity associated with them. This is an example of non-concomitant immunity, high-grade glioblastoma, a section of that showing a very high Ki-67 tumor proliferation. You all see that number on your report, but you don't look at the picture, do you? So. And the other way, stain the T cells, and you don't see a T cell there. There's a higher angle. You can see a lot of tumor proliferation, and there's no T cells there. Well, it's because the location, most likely, because T cells don't go into the brain normally. But that is the fact that when you cut out the tumor, you don't see immune response. But there are exceptions. Okay, so in this case, yes, you can see T cells in this necrotic area. It is probably due to the T cells that cause this. then you can say lack of tumor proliferation in that specific area. You can say that's what I'm saying. Look at it functionally, look at the distribution. Look at like a war map. Where's the enemy, where's the troops? Are they contacting each other? Who's winning what? So in this case, you can see that's the exception. You don't see that, maybe less than 10% of the cases you would. Then that patient would get a better prognosis later, most likely. Now this is a stage 3 ovarian cancer, rush to surgery because palliative reason, and then most time you will see there's a lot of tumor proliferation and with a barely or barely small amount of T cells and immune responses. Now with the immunogenic breast cancer, I said stage 2, they have better prognosis, even just surgery or neoadjuvant plus surgery. They usually have very good prognosis. And the reason for that is most associated, at least we think the reason for that is because they are usually immunogenic. Look the whole tumor, like I said, not just look a part of it. This is a tumor with 2 areas representative. This area represents a good tumor structure, not destroyed, but with T cells in between in the stroma. But we're very active tumor proliferation in this area. But then you look at the other area, then you can see massive T cells get out of the stroma, start getting into the tumor, and associated with the tumor being destroyed structurally and or inhibited for proliferation. Now another tumor, Clncio Carcinoma, have usually bad prognosis, very malignant. This is a biopsy of one of them. It's a representative. Usually you don't see signs of a T cell response in this case, and very active tumor proliferation. But there are exceptions. This is the one that they found the Clncio Carcinoma by physical checkup, no symptoms, and it's there, and no metastasis, so they had a surgery on it, and no wonder you can see. This area, most of the area actually has changed, has lost its so-called structure. This is a Clncio Carcinoma structure, adenocarcinoma. But then you don't see that in the rest of the area. But then you see rest of the area full of T cells infiltrating them, and they have changed into a more like a sarcoma type of a solid low differentiation. They sometimes even pathology call it low differentiation. It's not low differentiation, it's just lost structure. But then there's a remaining one in the core with a tumor proliferation, but with no T cell infiltration. But you look at the trend, think about it in a kinetic way, and maybe giving a little bit more time, this one will be gone too. So we can't say that it is going to be self-healing, self-cured, but that's a possibility. This is a physical checkup fund. If they didn't find it, would that patient get into a Clncio Carcinoma, die of it in 6 months? Who knows? That's a question. Now, this is what we call a special group of lung cancer, find out by physical checkup, 1 to 2 centimeter, once the doctor cut it off, then take a look at it. So there's not much of tumor proliferation in this tumor, and there's not much of structure left either. And you can see associated with a lot of dense T cell infiltration, and that again make one wonder whether that will leave that on without physical check, but will that patient die of cancer next year? But on the other hand, yeah, there are bad ones, lung cancer, small cell lung cancer. This is what you find in a lot of cases, overwhelming, more than half of them will have very low differentiation small cells proliferation and without T cells present. This is a biopsy, but I'm sure they can do surgery on them, but if had they done it, I'm sure there's a lack of T cell response on it. Now, 2 examples of what are you using this information. You could use this information. I'm not saying it is definitely true. It's not established, but we're thinking, for example, this is a biopsy from pancreatic cancer, okay? This one doesn't have a severe, it has a large tumor, primary, no metastasis, but they can't, its surgery is going to be risky and difficult, so there's no decision on it. But look at the biopsy, and we found a massive T-cell infiltrator associated with a lack of tumor proliferation. So in this case, what the doctor would suggest, well, we can't do surgery, then go to chemotherapy. But point is, they don't even, if the tumor is not proliferating, the chemotherapy won't help much, because all chemotherapy drugs were selected on proliferating cells, and they're targeting certain metabolism pathways of replicating cells. So the last one example is, this is another one of cancer, pancreatic cancer. This one is one that we could do surgery on it, and after surgery you can see most of this is 70% of destruction of the structure. This is a real tumor structure. You can see in the 70% of the area is gone, and associated with a massive T-cell infiltration, but only in this area with a less T-cell infiltration and still tumor receding. So what do you do post-surgery? That's another question comes up. That's what I'm saying. Using this, you can give you some thoughts. The final example is what we call the longitudinal change from a breast with a biopsy. Then we saw proliferation, and we saw some immunogenicity. It's not surprising that about 70% will have it. Then we did chemotherapy, then finally surgery. You can see the change. Tumor replication is completely shut down with a massive T-cells found within the residual tumor without tumor proliferating anymore at surgery. So this one will have a good prognosis. So the incorporation of anti-tumor immunity in surgery decision making, but at least you can consider immunological impact, considering it in each of your surgery. Is a good time, if we could, try to think about incorporate the surgery as a part of a comprehensive immune therapy. That's going to be something to do in the future. For example, surgery is the only way you can take a tumor tissue for vaccination, and sometimes vaccination is the only way, for example, for that glioma patient, that you bring an immunity to that patient by subcutaneous vaccination, for example. Now, so know your plan before surgery. That is more prepared in this case. Finally, I want to end my talk with a quote from Dunphy. Every time I read it, I feel proud of being part of, even though I'm not a surgeon, but being part of Dr. Norton's partner, because surgery still remains the only hope of a permanent arrest of cancer. The surgeon stands in a position of singular significance to the patient. Whether he realizes it or not, he is the knight in shining armor who is going to save the patient from the cancer dragon. His lack of interest or his withdrawal from the case when it is evident to all that the battle is not won takes all the hope away from the patient. Thank you. I'll take some questions.